we'll discuss hematochezia here. And hematochezia is pretty much always going to be lower GI bleeding. However, you can never rule an upper GI cause out. If you've got really fast transit, an upper GI cause may be behind it, rarely. But with hematochezia, when there is blood in the stool, it's usually going to be a lower GI cause. The only time we can really just at face value differentiate upper GI versus lower GI is if it's hematemesis, then of course it's going to be an upper GI cause, and if it's bright red blood per rectum, then it's going to be a lower GI cause. Okay, so we're going to talk about diverticulosis. We'll talk about angiodysplasia of the colon, and then intussusception, which is primarily a disorder of pediatrics, colon cancer, and then internal hemorrhoids. Meckel's diverticulum we talked about in the upper GI part, the part on hematemesis and melena. Inflammatory bowel disease, I would direct you to the gastroenterology section. I pretty much talked about all the surgical management for that in that section as well as the medical management. And then ischemic colitis, I discussed in the vascular section on mesenteric ischemia. And then infectious diarrhea is discussed in the medical section. Okay, so the initial management for any lower GI bleeder is pretty much similar to what you're going to do for an upper GI bleeder. So, of course, you're going to want to make sure that the patient is stable, and that's going to mean getting a bilateral large bore IV in them, and that's important. A little bit more in the upper GI cases where there's hematemesis, but it's also important in lower GI patients, just in case you need to transfuse them or you need to get fluids into them. You'll want to bolus them if there's been any significant recent blood loss, so vomiting or hematemesis, or if there's been any significant recent diarrhea, and then ensure that there's an airway that's secure. You'll want to get a CBC, a CMP. You'll probably also want to have coagulation panels, and then you'll want to have a blood type and cross-match, and definitely have red blood cells on hand. You'll also get an NG tube placed, and that's just in case you're concerned about an upper GI bleed, if there's anything in the history that makes you think that it might be upper GI, and you can differentiate that out if you don't get any blood through the NG tube. A lot of physicians, gastroenterologists, like to do an upper endoscopy just to definitively rule out an upper GI bleed, but it's not absolutely necessary. And then a colonoscopy is going to be important for almost all of the lower GI causes. So diverticulosis falls under a larger umbrella of what would be called diverticular diseases. And under diverticulosis, you can have diverticulitis, which is an inflammation of a diverticula in the colon. That's totally different. You don't have bleeding there necessarily. And also under the diverticular diseases, you have diverticular bleeding, in which you don't necessarily have an infection, but you do have bleeding from the diverticulum. And that's what we're talking about here. So we're talking about diverticulosis that is bleeding. This is not the same as diverticulitis. About 50% of all Americans over age 50 do have diverticular disease to some extent, but when diverticular disease isn't bleeding or isn't infected, there's really no symptoms, so you don't necessarily know. The reason it's probably that we know over age 50 is because it's at age 50 where you're starting to get surveillance colonoscopies to prevent colon cancer. So that's probably why we know this statistic. It's very common in in Americans and Westerners, Europeans in general, just because we tend to have a more processed, lower fiber diet. So diverticulosis is a big common problem here. Diverticulosis is the most common cause of lower GI bleeds. It comprises up to 60% of all adult lower GI bleeds. So if you have a patient who's got maroon-colored stools or has more commonly what this would present as a rapid hematochezia, then this should be number one on your differential, of course, especially if it's an older adult. Oh, and then, of course, diverticulosis is painless, too, and that's going to be important because some of these other causes are painful. So the history behind diverticulosis, this is a patient who may have possibly been previously diagnosed with diverticulosis on a surveillance colonoscopy. Patient may have had a history of diverticulitis, and diverticulitis is notable in that it causes left lower quadrant pain. You have infection. You can actually have, with diverticulosis, you can have intermittent left lower quadrant pain, but it's not going to be to the same degree as you would have during diverticulitis, during an acute inflammation. Usually diverticulosis, when it causes bleeding, is self-limited, and the patient's no longer acutely bleeding by the time they get to the hospital. But of course, if if you're going to the bathroom and you see a toilet full of blood, everybody's going to go to the hospital as soon as possible because that's a horrifying scene. So these patients will come into the hospital 99% of the time. The symptoms, so this is sudden, painless, and rapid lower GI bleeding. You don't have any pain fibers in your large intestine, so there's no way you're going to feel any damage here. So this is painless, but it's also rapid. The blood comes out of here very quickly. And then usually this is going to be frank blood, but it can also be maroon-colored stools, and that just depends on where the blood is coming from. Very common place to have diverticular disease is in the sigmoid colon, and so of course if it's from there, you're going to have pooling blood into the rectum, and then it'll be just frank blood coming out. But if it's diverticular disease in the ascending colon or in the cecum, then that blood will stick around in the large intestine for some time, and it will be actually more maroon colored rather than frank blood. Left lower quadrant pain is possible, but it's not necessary. We more so think of severe left lower quadrant pain when we're thinking about diverticulitis, which, remember, is a different thing. Labs, you're going to want to make sure, of course, that you have your CBC, which may show anemia. That would just be a sign of blood loss, possibly chronic blood loss. And then if you have iron studies with that, which you always want to get if you have a CBC that shows anemia, it's possible that the patient would have an iron deficiency anemia, and that just shows that they have anemia due to blood loss. So for diagnosis, assuming that an upper GI bleed has been ruled out, which you can usually do if it's maroon-colored stools or certainly if it's frank blood, then the best initial diagnostic step is going to be a colonoscopy. You'll have to admit these patients to the hospital because it takes about 12 to 24 hours to have the patient sufficiently prepped for colonoscopy. And like I said, most of the time the patient is no longer going to be bleeding by the time they get to the hospital. And so when you look into the colon, you won't find any bleeding source anymore. But you will find diverticulosis. You'll find the diverticuli. Treatment, if the patient is still bleeding, you're going to administer octreotide, and then endoscopic intervention. When you're doing your colonoscopy, you'll be able to do various different interventions that you can do. Sclerotherapy, I think you might even be able to band. But you just need to know that endoscopically you can do treatment that way while you're doing the diagnosis. Patients who get diverticular bleeding frequently, they can have resection they have these refractory cases that go on and on, but that's a second-line therapy. Octreotide and endoscopic intervention is what you're going to do to treat patients who have an active diverticular bleed if you're going in for colonoscopy. So here's a colonoscopy, and this is a diverticulum right here. It's pretty innocent looking. So this is probably just on a surveillance colonoscopy. There's really nothing here other than the diverticulum. Here's a couple of them here. Actually, 3 of them. 1, 2, 3. And this looks like the lumen of the bottle here. So here's a bleeding diverticulum. So you know this is bleeding because first you see there's blood coming out and pooling here, and then once you wash it out, you can squirt water through with your endoscope, you can see that there's a diverticulum here. So it's a diverticulum that's bleeding. And here's another one here. Okay, angiodysplasia is the number 2 most common cause of lower GI bleeding, but definitely less common than diverticulosis. It's asymptomatic until there is a bleed, and it's usually found in the cecum or ascending colon. So this is not going to present with bright red blood. It's not going to present, possibly might not even present as maroon stools. It might present as melena. So this will be melena or maroon stools. The thing with angiodysplasia is because it comes with the cecum and the ascending colon, it's going to spend some time in the intestine. So it's going to present quite differently from diverticular bleeding. The history for these patients, this is pretty much always in patients who are over the age of 40, but other than that, there's really no there's no common thread between all patients with angiodysplasia. So symptom-wise, bleeding is usually the only symptom. The bleeding from angiodysplasia is slower than that of diverticulosis, whereas with diverticulosis you have a rapid bleed, which may even be in the distal colon. With angiodysplasia, it's a slow bleed. And so this is blood that will be in the intestine for a while, and it may even be slow enough to the point where the patient doesn't even notice it. So presentation is usually going to be melena or maroon stools. Signs of chronic anemia may be present, and that's also because the patient may not notice it. They may have had a bleeding angiodysplasia for a while, and they just haven't noticed it until they notice melena or maroon stools or whatnot. This, again, is not painful. You don't have any fibers in the colon. Labs, pretty much the same as what you would have elsewhere. CBC would show anemia. Iron studies would show iron deficiency anemia. That just shows that you've got blood loss. For diagnosis, assuming that an upper GI bleed's been ruled out, the best initial diagnostic test is colonoscopy. So, this, just like the bleeding diverticuli, has sort of the same workup. The only difference is that it's the number 2 most common rather than the most common, and also that this is a slower bleed, and so it would show melena or maroon stools as opposed to maroon stools or bright red blood, frank blood. But then when you go in with your colonoscopy, you'll be able to find the angiodysplasia. That looks totally different than a diverticuli. Treatment is going to be endoscopic intervention. So this is done via coagulation. So here's an angiodysplastic lesion. And all it is blood vessels that coalesce and bleed. So here's another one right here. And so if you had a patient that's got a history similar to what you'd expect with angiodysplasia, and then you find this, you make your diagnosis. And patients often will have these all over the place. Although sometimes it may just be in one area. The area, though, that you're going to look is the cecum, proximal large intestine, ascending colon. Okay, intussusception. Now, this is a disease of pediatrics. This is the most common cause of lower GI bleeding in children, particularly in infants. What intussusception is it's a telescoping and invagination of a proximal part of the small intestine into a more distal segment. So the proximal portion is pushing itself into a more distal segment, and that's going to cause problem because, one, it's going to obstruct the intestine, and 2, you're going to get ischemia because it's going to twist the blood vessels around. And because you get ischemia, then you get necrosis and then therefore bleeding. This usually occurs in infants, younger than the age of 2. It very rarely occurs in newborns, younger than 2 months old or a month old, and it rarely occurs in older children, toddlers, elementary school age children, teenagers, adults. So anytime when it does occur in a newborn or in a child over the age of 2 or an adult, it should prompt investigation for a mass, because a mass increases your risk of intussusception. So a tumor or even Meckel's diverticulum, that can increase your risk of intussusception. So you should definitely be looking for that if it's an older patient. Usually this occurs in the ileum or in the cecum, and the symptoms are going to be sort of this progression. So it'll start out as, and remember here we're thinking about like infants, so they're not going to tell you they've got pain. So it'll start out as nausea and vomiting, usually your typical vomiting, non-bilious vomiting, some abdominal pain. If you were to check them at this point, they may have some occult blood in the stool. And there would, because there's intussusception, they would certainly have this sausage-shaped mass, and what that is the actual intussusception. It's the intestine going down into the distal intestine. It's telescoping in. As this goes on and you get the ischemia and the necrosis, then you start to have more obvious blood in the stool, and it's this current jelly stool, and it's usually at this point when the parent brings their baby in, because this definitely is never normal looking. But one of the things that you're going to be, that you'll need to be able to recognize is the sausage-shaped mass, and you'll need to know current jelly stool. This is intussusception. If it's very late on in the case, they may show signs of abdominal distension, which shows possible perforation, which certainly any time that you have ischemia in the intestine, you can get perforation. And then signs of sepsis, which would show that they've got bacterial seeding into the abdominal cavity. The best initial diagnostic test when you suspect intussusception is an ultrasound of the mass. What you're looking for is a target sign, and that target sign is very characteristic of intussusception. The treatment is going to depend on what stage you're in. Most of the time, the best treatment is going to be a barium contrast or air enema, and that will also confirm your diagnosis. And once you do that, because of the pressure moving backwards, moving proximally against the way the intestine is telescoping, it'll relieve the intussusception. So it's both diagnostic and therapeutic. Now you're going to be expected to know, I'm sure you're going to be tested on the test when not to do a barium contrast or air enema. And that is going to be when there are signs of perforation. So if the patient has abdominal distension or signs of sepsis, in that case you're going to do an open surgical reduction, as well as resection of the necrotic bowel. You may also do that if the enema fails, or if there's any signs of, like I said, if there's any signs of perforation or sepsis present. So this is a sonography, and you're looking perpendicular to the, you're looking head on to the intussusception. So here's your distal segment of bowel in the middle here, and here's your proximal segment. This is your proximal segment of bowel here, that's telescoping, and this is your distal segment of bowel here. So it's a target sign. Here's another one, a little bit less obvious here. So here's your proximal part, distal part. Here's another one. And here's two views here. This is kind of nice. So this is that transverse view where you're looking at the intussusception head on. And then here's another view where you actually see it from the long way, pushing in. Colon cancer. So I talk about this in the medical section pretty much completely, but just to recap, because colon cancer often does present as melanoma maroon stools or frank blood. So the history for these patients is a family history of colon cancer, personal history of colon cancer, personal history of inflammatory bowel disease, high-fat diet, old age, some of those familial polyp disease, HNPCC, FAP, etc. Symptoms, of course, may present as melanoma maroon stools or frank blood. That's going to be dependent on where the tumor is. Usually causes a change in bowel habits, especially if it's in the left colon. It's going to cause a change in stool caliber, and the reason for that is because the stool is squeezing through that area between the tumor and the rest of the large intestine, and so as it squeezes through there, you're going to get a narrow, more stringy stool. A lot of times they call it pencil thin. If it's in the right colon, it can cause diarrhea. Anemia, general symptoms of cancer, which would be fatigue and weight loss. Labs, what would you see? Of course, anemia, again. Iron studies would show iron deficiency anemia. It might be mixed with anemia of chronic disease. That's just because you've got cancer and inflammation going on. Chronic disease, anemia of chronic disease would just push your TIBC down, whereas your TIBC, if you remember back to hematology, would be higher in patients with iron deficiency anemia. If you have a chronic disease, it can push that down, so it might be in the normal range. For diagnosis, assuming, of course, that you've ruled an upper GI bleed out, then the best initial test is going to be colonoscopy. And in this case, of course, you're going to want to have a biopsy of the lesion. Usually, you'll know you'll know cancer when you see it, but of course, you'll want to have a biopsy of that for definitive diagnosis. The treatment is going to be resection, and in most cases, you'll also be doing chemotherapy as well. Non-cancerous polyps can also cause bleeding as well. So just because you're going in doing colonoscopy doesn't mean you'll always find cancer. It may be caused by a polyp. So it's not cancer all the time. Okay, this is Saint Fiacre. He was a French gardener, and he is the patron saint of hemorrhoids. And that's because he was gardening so much all the time. He was squatting, and that causes the increased abdominal pressure, which resulted in him having hemorrhoids all the time. Here's another piece of art that I found of this saint, so you can make of that what you want. So hemorrhoids are inflamed thrombosed vascular structures, either in the external or internal anal canal. It's the dentate line of the, if you remember the anatomy, the dentate line separates the external and internal anal canal. And it's extremely important to remember the difference between external and internal hemorrhoids. So internal hemorrhoids usually are not painful, but often they bleed. And this is what we're concerned about here. Whereas with the external hemorrhoids, which are the ones that people complain about all the time because they hurt, those usually don't bleed. So the exact cause of hemorrhoids is unknown, but it has something to do with increased abdominal pressure. So things that increase abdominal pressure would be straining, especially patients with constipation. They're going to be straining to get the stool out. Patients who are pregnant, just because they have the fetus there, it's going to increase the abdominal pressure. Liver disease is going to increase the abdominal pressure, especially if there's ascites present, and also because it's going to back up the hemorrhoidal arteries and structures down there. So the symptoms with internal hemorrhoids, this is not going to be a significant blood loss, but it's going to be enough where that the patient notices that when they're using the toilet tissue, they'll notice streaks of red blood on the toilet paper. So it's just mild, bright red blood per rectum, and it's always going to be bright red blood per rectum because this is coming right out of the anal canal, maybe 3 inches past the anus. So it's not going to be melena by any means. It's not going to be maroon stools. This is just going to be blood that's noted on the toilet paper. Often this is in conjunction with a high risk for hemorrhoids. So pregnant patient, patient with constipation, irritable bowel syndrome, liver disease, etc. But anybody can get hemorrhoids. Even another thing to think of is athletes. If they're working out a lot, doing a lot of lifting, they can strain, and that can cause hemorrhoids too. To make the diagnosis, often you can just make it on physical examination. With the internal hemorrhoids, you may not see the hemorrhoid. Sometimes the hemorrhoids will protrude out, but not all the time. And so you'll always need to do a digital rectal exam. Of course, if the internal hemorrhoid is protruding out, or if it's an external hemorrhoid, which remember does not bleed, so it's not really what we're talking about here. Those will be visible just on looking at the patient's anus. But if it's an internal hemorrhoid and you suspect it's an internal hemorrhoid and you can't necessarily feel anything on digital rectal examination, then the diagnosis can also be made with an anoscopy. And remember to differentiate out anal fissure. Anal fissure can cause bleeding. But an anal fissure is a tear of the rectal mucosa. So that's not the same as a hemorrhoid. Usually anal fissures occur in younger women who have a very tight rectum. And then for treatment, it's usually going to be done by rubber band ligation or sclerotherapy. And you'll also want to make sure that the patient increases fiber in their diet and take over-the-counter stool softeners, especially if they have constipation. But usually that's going to be enough. If patients have chronic internal hemorrhoids, and this is a chronic problem, and they're just like, "Doc, I'm sick of this," they can be definitively treated by hemorrhoidectomy, which is a more invasive procedure and has to be done by a surgeon. But for the most part, this is not a really big, this is not a dangerous problem for people. This is just more of a nuisance. So hemorrhoids can be classified. It's more complicated to classify internal hemorrhoids, sort of because external hemorrhoids kind of all look the same. The external ones, remember, are the painful ones that usually don't bleed. Internal hemorrhoids, though, are split up into 4 degrees. So the first degree being the least severe and the 4th degree being the most severe. So first degree, these are the ones that don't prolapse outside the anal canal. However, you may be able to feel them on digital rectal exam. Second degree, these prolapse, but they spontaneously reduce. Then the 3rd degree prolapses, but they're manually reducible. You can put them back into the anal canal. 4th degree, which is the most severe, prolapses outside the anal canal and can't be reduced manually. Okay, so this is an external hemorrhoid. Of course, this is not going to bleed. And really, I wouldn't imagine you'll be asked to just look at a picture and know what kind of hemorrhoid it is. I mean, this is obviously an external hemorrhoid, but this would also be painful, and that's the dead giveaway that it's an external hemorrhoid. But I'm just showing you these pictures for reference. Okay, so this is an internal hemorrhoid. This is a pretty bad case. This looks like it might be 4th degree, but really the only way you can tell is by trying to put it back into place. And here you can also see what appears to be bleeding. Looks like there's some blood down here. So here's an internal hemorrhoid on anoscopy. Multiple hemorrhoids. And then here's another internal hemorrhoid. And another one, this one actually is actively bleeding. So the other things that can cause lower GI bleeding, cause hematochezia, are Meckel's diverticulum, which I talked about in the melena and hematemesis section. Meckel's diverticulum tends to cause melena. However, in children, it certainly causes hematochezia. So that's sort of the difference there. In adults, this is going to cause melena. Children, it causes more hematochezia. So Meckel's diverticulum is just a vestigial remnant of the distal small intestine. It has pancreatic and gastric mucosa. The gastric tissue secretes pepsin, and then that's going to cause ulceration and bleeding. Typically, you find this in adults, but it can be typically you find this in children, but it can be found in adults too. For diagnosis, you do a technetium 99 scan, and I show you pictures of that in the hematemesis and melena section. Treatment is a Meckel's diverticulectomy. Inflammatory bowel disease, like Crohn's and ulcerative colitis, I talked about ad nauseum in the medical section. This is complex. These are complex immune-mediated diseases. Not technically autoimmune diseases, but they look like one. And they affect either the colon only, which would be ulcerative colitis, or the entire digestive tract. Really, the only way you can tell these apart, though, definitively, is with biopsy. So that's the way you diagnose it. Treatment, there's tons of things. So the ASA derivatives, immunomodulators, biologics, steroids for acute flares. Surgical therapy is only really undertaken for ulcerative colitis, and that would be a total colectomy. And because ulcerative colitis only affects the colon, if you take the whole colon out, that's basically a cure. Ischemic colitis, mostly as far as acute mesenteric ischemia, this is an infarction of the SMA or IMA, usually the result of an embolism. Could be secondary, usually it's secondary to atrial fibrillation or another cardiac cause. It can also be secondary to thrombosis. This is, of course, associated with atherosclerosis, atrial fibrillation, other heart problems. Diagnosis is going to be made on angiography. Treatment will be based on the underlying cause, whether or not this is an embolism or if it's thrombosis. It can also be caused from hemodynamic shock. So this will always, though, include a broad-spectrum antibiotic and then segmental resection of any necrosed bowel that's present. And then infectious diarrhea is a medical topic. This is never going to be intervened surgically. This is acute onset diarrhea. Most of the time the patient won't have visible red blood, although they may, but they'll always, when it's bloody diarrhea, they'll always have white blood cells that are present. And so this is actually diagnosed with a stool lactoferrin test. It's a little bit easier than looking for red blood cells. These patients, of course, because it's infectious diarrhea, can also have a fever and appear sick. The only reason we're going to treat this is if the patient is really, really sick. So Salmonella and Campylobacter are the most common causes of infectious diarrhea. And the only exception to treating them with antibiotics, even if they really do appear sick, is if it's hemolytic uremic syndrome, which, remember, is caused by E. coli 0157H7. And hemolytic uremic syndrome would show the classic clinical presentation of low platelets, jaundice, and a high indirect bilirubin. And so you should never treat those patients with antibiotics, nor, I should add, should you treat them with platelets, even though they have low platelets. These patients are treated supportively. So if you have any questions, feel free to let me know.